So for the purpose of my talk, I will let science speak for itself. And we are discussing 2.2mm incision in this case. Now, clear corner incision today is not only about surgical performance intraoperatively, but importantly about infections and surface symptoms because patient demands are different. And more importantly, about surgically induced astigmatism. So the real question is smaller incision actually a safer incision? Now, this is the smallest incision you create in an eye. This is a 1mm incision. But in no way can this be called a self-sealing incision, because if you look at the wound gate and the distortion, not only is it a leaky wound, it's also going to induce a lot of astigmatism. To substantiate it, as a published study by us, this is a 1.1mm side port incision that's frankly oozing in the trypan. If you notice on the superior side port, there's a frank ingress of trypan, and likewise a frank ingress of bacterial cultists, fluid from the cul-de-sac can happen. And this is a 1mm incision. So we did a study to compare the incision integrity and clinical outcomes with both the platforms, the 1.8 with the Samaresh and the 2.2mm with the Alcon Infinity platform. It was a prospective randomized clinical trial where we randomized 50 eyes to 1.8 and 50 eyes to 2.2 incision. Needless to say, surgery was performed by a single surgeon using a standardized technique and was competent in both the machines. This is a representative image of both the incisions being performed. The parameters in both the eye groups were comparable. We understand that the Samaresh was being used with the longitudinal, and worldwide Infinity is used with the OSA technology. Appropriate IOLs that were appropriate to this incision size were used by using a company guided injector. And we compared the incision integrity using trypan glue ingress in the anterior chamber. How it was done is at the end of the surgery, after forming the chamber, the speculum was removed, trypan glue was thrown over the patient's eye, and patient was allowed to relax and actively blink the eye while under the surgical field. At the end of 2 minutes, 0.1 ml of aqueous aspirate was withdrawn from the anterior chamber, which was then sent for UV spectrophotometry. Now this is a graph, this is a table showing the analysis. Group 1 being the Samaresh and group 2 being the Infinity group. If you notice, the values are in log units. So a higher log unit means a lesser amount of trypan in the patient's eye. And here we can see the group 1 or the 1.8mm incision has significantly higher trypan ingress as compared to a 2.2 incision. Also, if you look at incision enlargement, the incision enlargement was high in the 1.8mm as compared to a 2.2. This is the incision size, 1.8 when the wound construction, and the incision enlarges to a 1.9mm at the end of phacoemulsification. While at the end of IOL implant, this incision enlarges further to a 2.1mm, so 1.8 has become 2.1 already. The mean incision enlargement with the 2.2 incision group was 0.25mm. Surgically induced astigmatism, although not clinically significant, if you notice the group 1 has a mean of 0.7 as compared to a 0.37 of a 2.2mm incision. So the astigmatism was higher with the 1.8 group. Visante anterior segment OCT imaging showed more endothelial gaping and more endothelial misalignment in the 1.8mm group as compared to a 2.2mm group. And both these findings suggestive have been published in literature to be at higher risk for endophthalmitis postoperatively. We also went ahead and published this, our study. So it is not the phaco, but the clinically non-apparent stretching and distortion in terms of either a mechanical damage by going and maneuvering through the incision, or a thermal damage, that is in small incision, big sleeve, and trying to perform phaco through that is what we talk about. Now look at this representative video. This is a company recommended incision size 1.8 with the probe and the sleeve that is recommended by the company, and it is so difficult for even an experienced surgeon to enter into the patient's eye with this. We also went ahead and done a histomorphological analysis, an experimental study, where we looked at histomorphology of these two incisions at the end of surgery. And if you look, it clearly revealed in the histomorphology, on the right side is the 1.8mm group, which shows greater stromal damage over here, more hydration with the 1.8mm group, and more collagen denaturation as can be made out over here. It has been published in literature that the 1.8mm incision is better with a softer cataract, while the 2.2mm incision works good with the higher density cataract, and that is where you actually test the performance of a phaco system. So it is the incision distortion which determines the incision outcome and not the size. And here I rest my case. Thank you.